So this is a dog with a primary hyperparathyroidism, and it's got bladder stones as a result. So we're just going to do a quick cystotomy and then go to the parathyroid approach.
Well, don't let me forget, but when I was hosting for you, I taken a container because I prepped some food.
Okay.
And I just moved it back.
Okay.
In my backpack.
No worries. This is the corner here I don't like. It's just a loose skin. So usually I prefer to come down the midline and more of a curve down here, but it's way too far lateral there too. So I find the real challenge with these is how to manage them post-op. Very few of them will need vitamin D or calcium supplementation in the form of calcitriol, but we don't truly know who requires that and who doesn't. So one option is to keep them in hospital for 2 to 3 days, monitor calcium, and see whether or not they require calcitriol, and go from there. But that means the cost of 2 to 3 days in hospital, and all those tests for what's a fairly minor surgery otherwise. So the other option is to immediately put them on calcitriol and send them home same day like this patient, or the following day, and then do weekly ionized calcium tests to see where they're at and wean down the dose as required. So that's less costly, particularly in the short term, when you think of how much hospitalization costs, but means multiple visits and multiple visits to get those blood tests.
Do you ever start them on Tums?
No, Tums is kind of more of an emergency.
Okay.
So I've never done Tums. Who's this? What's this? What's that?
The chest X-rays from
Willow. Who's Willow again?
the liver lobectomy.
Okay. That look good? Let's get that sponge underneath.
Maybe a section on for you.
Okay, so we're just going to make an incision into the ventral aspect of the bladder, fairly close to the urethra, just because that's where gravity tends to. Ready, 1, 2, 3. That's where gravity tends to take the the stones. Nothing up there so far. They're usually down here. I can feel them.
You want a red rubber?
Yeah. Give me a red. Hello. Can we have a red rubber catheter and some lube, please? 8, yeah. Let's do the short one. Here we go. Just we'll grab. So it's a slightly less traumatic way of exposing the bladder rather than Gelpies or that kind of thing. So we're just going to catheterize the penis here and then see whether we can physically force anything into the bladder. And then we'll start flushing after that. There we go. So you can see a whole lot coming in now. So there's some calcium oxalates coming in now. There are a number of other ones down there, so we're just going to have to flush those out. In a female dog, I wouldn't worry as much. You'd pee these out, but in the male dog, a little bit more worried just because potential for any of these to get stuck. Okay, yeah, you can.
Can you pull back on the catheter a little bit, or just flush?
Actually, why don't you? And then we'll just advance. So flush, advance, flush, advance. Yeah, I can't see. Yep. Let's pull back and do it again.
Some grit in there.
You can come back further if you want. Let me just get that around there so I'm not fighting with you. Any grit still?
Feels okay.
Okay, let's just run it one more time and then we'll close up after that. So we're seeing nothing come out. Yeah, that's great. So we'll just close up now. So you always want to make sure that you've flushed at least twice with no no stones. Just to make sure that you're... What's that? Yeah, we haven't finished yet though. Okay, thanks. So we've got a few in here. Like these are all outside the bladder, but and they'll probably never do anything. But still, we'll try and get them out.
You can section off.
So while studies show that a single layer is sufficient for closure of bladders, I typically do a second layer just in case. It's probably unnecessary, but still. What's that? Stones are out. be honest, it's just where the camera was. So
I've spoken to a foreign body, and I've spoken to the fracture.
uh-huh.
So those are both good to go, and we feel like this is getting an ultrasound as well.
Okay.
So we'll go from there. The fracture looks a bit tricky.
I don't know. First of all, I think we should get obviously repeat rads.
Yeah, that's what I like. The problem is the dog has a high SAS, and that one. It's just that one view that like has me worried that it's three pieces.
But it's also non-displaced, so
Yeah.
it'd be pretty easy just to put a lag screw across and then cross pin.
I figured like a kind of transcondylar lag screw and then the kind of special distal femoral plate.
I was just going to cross pin, but
Oh,
do we have the?
we do. Jeff checked yesterday when I came in.
Okay.
Just because she's such a big dog and she's quite
Yeah.
active, I think the stronger the better. The only other thing I talked to them about in the console was just having a foot in the joint and making sure there was no instability
Yeah.
there as well, because it was.
Do you want to count
The
that?
car was moving at 80 or so it was fairly high impact. Just want to make sure she doesn't have like a deranged like blood pump or something.
Yeah. Sounds good.
But yeah, they're all.
I'm going to close that while I start there. So we're just going to switch here. Matteo is going to close the bladder, and I'm going to switch to the neck, and just let me find it first, and then we'll. That sounds good.
Yeah. We've got like three of these medications out there.
If you're free, you can start. You can do at least the punch parts of the perineal one.
Yeah, I'll see where they're at with all of them.
Yeah. I'm not so sure about the knee one. I need a better feel. Okay, so I'm just going to move this now. So all Matteo's going to do is close the linear elbow, then subacute, and do intradermals. So now we're just going to switch to the neck here. That's better. Okay, we'll just reposition that. Just right. If you go to that pad right there, there's a rotation pin. There's a rotation. Other way. Keep going, keep going. That's good there. Yeah, great. Thank you. So what's your name? Chris?
Great.
Grace. Thank you for that, Grace. Okay, so that's the larynx there. So we're just going to do a ventral midline incision here. Now we're just trying to find the ventral midline and the sternocleidomastoid and thyroideus muscles here. Looks like it's there. Okay, so there's our trachea exposed. Let's get our Gallipies in there to find the thyroid and the parathyroid. So there's a thyroid gland on the right side. And grossly that looks pretty normal. So just expose the other side, then we'll have a palpation. You should always check both sides anyway because there can be more than one parathyroid mass. You see it okay? So that looks pretty convincing there for a parathyroid mass just here. So these parathyroid masses are usually quite small. So anything, they're always less than a centimetre. Well, not always, but almost always less than a centimetre. What I might do is get and if I can get you in with that. So, actually, I just might swap sides with you. You can get in there. Thanks. I'll actually use the iris scissors as well. So I'm pretty sure that's our thyroid mass. Am I heading away?
Yeah.
Okay, sorry. Pretty sure this is our parathyroid mass just here. Just going to work around that. And just usually what I do is for something so small, a complete thyroidectomy, just to make sure we get margins. So what I'm going to do is just quickly swap over to the other side, palpate that, make sure it's not on that side, and then come back here and do the thyroid parathyroidectomy. So, yeah, if you get back in there again, yeah.
For opposite knee, do you want the whole like leg shape basically?
No, just the knee.
Just the knee area.
And the perianal area.
Yeah, okay. Copy.
so this is where it's good to do both. My head in the way. I don't think that's a mass there, but I am going to remove that just in case. Okay, so just took the cranial pole of the right. Let's just put that on there so that moves it. And we'll come back to the left side now. I do think this one's the more likely one, so I'm just going to come down this way. So that's what I think it is, just there.
Why do you think the other one wasn't one?
It just didn't look, it looked like more of a normal one, a normal parathyroid. Okay, so that's as simple as that. We'll just close up now. No, so we'll need two separate ones. That's the 2A? No.
The 2 is in the cup.
In the cup. I'll give you that. No, just let's wait, please, while we get it closed. Did you want to close?
Sure.
Do you need any instruction, or
I think I'm okay.
you comfortable? Okay.
Yeah.
Where's the history charts? So I need 2 to... Yeah, that's good.
I'll go on the other side. I'll go on the other side.
So that's the left. That's the right cranial. And then these are the stones.
Do you want those in formalin as well?
No, it's just a jar. No culture, just a jar.
Chris, do you mind just checking and seeing if there's any like plain jars with nothing in them?
I'm going to jump out and do these biopsies. So any concerns, obviously Matteo will help you out. Okay. My needles and the scalpel blade are in the sharps. And 1, 2, 3.
And then you mentioned the typical post-op analgesia plan for this patient. I have discussed NSAIDs down just to make sure that we're all normotensive and doing well post-operatively.
Yeah.
But that's about it. Are you okay with that?
Yep. And 5 lap sponges.
Perfect. Thank you.
So Matteo and Reno are just going to close up the 2 wounds while I get on to some biopsies. So the plan for this dog is to send him home today and on calcitriol, and he'll come back on a weekly basis to get ionized calcium blood tests to see where his ionized calcium is sitting, and then weaning down that calcitriol depending on his ionized calcium blood tests. We'll see you for the next one.